Hello. Today we're going to talk about Chapter 9, Joints. We're going to look at what makes up a joint, how different joints move, and then we'll look into some of the different joints throughout the body. We will check out the rest of them in lab. So all of our joints are going to fit into different classifications. But a joint in general is a point of contact between two bones and cartilage, or bones and teeth. These all make up different joints throughout the body. We're going to have fibrous joints, where these different bones are held together by dense, irregular connective tissue, that collagen fibers. We have cartilaginous joints, where we have hyaline cartilage or fibrocartilage that's going to hold or unite these two bones together. We also have synovial joints. These are the most common joints in the body. There's a capsule around that joint that's going to wrap between the two bones that come together. There's a lubricated space, and then called this articular cavity, and they're also lined, each side of the bone is also lined with hyaline cartilage. So let's go through the different types of joints that we just looked at, and we're going to break them down even further. So we said those fibrous joints, they're held together by that dense, irregular connective tissue. There's very little to no movement on those joints. So here's some different examples. We have sutures. Think about the bones of your skull. There are separate bones in your skull, and they are all held together by sutures. Those sutures, again, is that dense irregular connective tissue that is holding those two bones together, like that coronal suture that separates that frontal bone from the parietal bones in your skull. They usually have this irregular kind of zigzagging kind of feature to them that interlocks the edges of that suture together. Why? Because we're trying to decrease that chance of having a fracture in that bone or of that joint. So I mentioned the skull. And by the time you're an adult, those joints are immovable. They don't move at all anymore. In a child, they're still slightly movable because in a child, that skull is still growing. So it needs to allow for some movement as that child grows. Shock absorption. So they're helping to prevent damage to the brain. So say a soccer player takes their head and hits the ball. Those sutures and those bones of that skull are absorbing the shock so it doesn't go down and damage the brain. A synostosis is when we have complete fusion of two bones. We have this happen in our body. We have synostosis, but they fit under that suture category. The next type is a syndesmosis. This is a fibrous joint, and there's distance between those surfaces of those bones. So we have the interosseous ligament. This is between the tibia and the fibula. So your lower leg, between your knee and your ankle, there's two bones in that lower leg. There's connective tissue, that irregular connective tissue that is like a sheet that holds these two bones together. There's limited movement between that tibia and that fibula. They move very slightly, but that's called an interosseous ligament. We also have an interosseous membrane. Again, that dense irregular connective tissue, and it's between the radius and the ulna, so your forearm. It allows for some movement. That some movement allows that radius and that ulna to rotate over each other when you pronate or supinate your hand. So when you take your hand and take your palm up versus palm down, that's supination up, because it has supination has the word up in it. So you can think of it as your palm up when you're supinating. Pronation has the word on in it. So hand down, it's on the table. So that's when you pronate and supinate your hand. That interosseous membrane that's holding those two bones together is a sheet that travels that entire length of that bone, is allowing your arm to move. The other one, symphysis. This is like a peg in a socket. Your teeth. Your teeth are all symphysis joints. Again, there is dense irregular connective tissue that is holding your teeth in their sockets. So here's these examples. This suture, you can see this irregular kind of membrane that is happening, or these joints that are kind of interlocking in together. There's a very slight ligament here that is holding these two bones together to make that joint. Now we have this interosseous ligament. As I mentioned, it's kind of like a sheet. So this entire thing here is one large sheet of that dense irregular connective tissue between this tibia and that fibula, holding these bones together. And then we have this symphysis. We have this denticulate or periodontal ligament. Two names, same thing. This is a ligament that I'm kind of coloring in yellow here that is holding your teeth in place. It travels the entire length of the tooth that sits inside of that socket. So these are different types of fibrous joints. Next, we'll look at cartilaginous joints. Again, a cartilaginous joint has very little to no movement. They can be connected by that hyaline cartilage or that fibrous cartilage. So we have a synchondrosis. This is between that very first rib and the manubrium, the top of the sternum. In a synchondrosis, we have that cartilaginous joint. So we have that bone, cartilage, bone. So that cartilage is holding that bone together. So up here, we have this first rib. Here's that cartilage. Here's that manubrium of that sternum. So this cartilage is helping to create that joint that makes up that synchondrosis. We have epiphyseal cartilage. We talked about those epiphyseal plates that make up growth plates. That is that hyaline cartilage and their growth centers. So those are where those growth plates that help our bones grow longer as we get taller through adolescence, childhood, adolescence. If there's any break to that epiphyseal plate, it can actually affect the growth of that bone. That bone may end up shorter where it was broken than on the other side. So it can be pretty detrimental. You can end up with a shorter limb by breaking your bone at that epiphyseal plate. But that epiphyseal cartilage, here's examples in the femur. Here's a growth plate in that femur. Here's another growth plate in that femur. These are both hyaline cartilage that's helping this femur to grow longer. And then our last type is a symphysis. The pubic symphysis, I'm sure you've heard of that. This is an example of that pubic symphysis. This is fibrocartilage that is holding these two hip bones together in the front. So that symphysis joint, both ends are covered in hyaline cartilage, and then we have a fibrocartilage disc. So what this is saying is there's hyaline cartilage here. There's hyaline cartilage here that's lining that joint. In the middle, this is that fibrocartilage. That is what makes a symphysis joint. Where else do we have them? Between the body and the manubrium of the sternum. So let me come back here to this first picture. This is what I wanted right here. This is another symphysis joint. Here's another symphysis joint. So between the vertebrae in your back, we have a fibrocartilage disc with hyaline cartilage that's going to line each bone. So here again, there's hyaline cartilage with that fibrocartilage disc between. So between every single vertebrae in your back, we have a symphysis joint. That is what this is saying with those intervertebral joints. So these are different places. They allow some movement because you're able to move your back. So it allows some movement. That sternum's going to move every time you breathe. So it allows for that movement to happen. That needs to. It may be very minimal, but it does allow some movement in there. And then we have our synovial joints. In our synovial joints, again, they are most common. They are freely movable. Some have great amount of movement. Some have slight movement. But what sets a synovial joint apart? It has a capsule that wraps around that joint. It has fluid in those joints. It has that hyaline cartilage that helps reduce friction and it helps to absorb shock. Here's some interesting research and stuff that's been done, a autologous chondrocyte implantation. So there's been damage to the cartilage in the knee joint. So there's ways they can fix it now. What they can do is they can go in and they harvest some healthy chondrocytes. from somewhere in the body. They're going to culture it in a lab for 6 to 8 weeks. In other words, they're going to grow more cartilage. They're going to make 5 to 10 million cells. And then they're going to go implant that back into the knee joint where that damage was. It takes about 10 to 12 weeks for everything to kind of come back together where you can fully bear weight on that joint again. But it's replacing damaged cartilage with new fully grown cartilage. It's kind of a new thing in probably the past 25 years that they can now come in and do. It's really cool. So back to synovial joints. All synovial joints are going to have an articular capsule. So they're going to have this capsule between here and this synovial membrane here that's going to wrap around every single synovial joint. This isn't your finger. There is that, I'm going to go here instead, hyaline cartilage that lines both joints. We have synovial fluid that is found in this space. So every single joint is going to, synovial joint is going to have these features. So this articular capsule, it's made up of that fibrous layer and then that synovial membrane. That fibrous layer, and that dense irregular connective tissue that are made of ligaments. These ligaments help to resist strains or tears. It's helping to hold these bones in place. That synovial membrane is going to be areolar connective tissue. Again, that packing material, most common connective tissue in the body that's got that collagen and elastic fibers. We can also find articular fat pads in that area, which are collections of adipose tissue that help to protect that joint. Your knee has several little fat pads. Your elbow has fat pads in it. They're helping to cushion and protect those joints. Have you ever heard somebody, or you may say yourself, that you're double jointed? All that means is that articular capsule and those ligaments have greater flexibility than somebody else. That allows for that increased range of motion to that joint. The problem with people who are quote unquote double jointed and have this greater flexibility, what it creates is a less stable joint. Means these people have a lot greater chance of dislocating that joint. So while it's kind of cool, it's a fun party trick to show people some double jointed, this extra range of motion to these joints. It just means that that joint is less stable. It's more likely to be damaged. So doing it all the time, moving that joint to show how it moves like that, it's not the best thing to do because it's creating less and less stability by constantly doing that. So that's synovial fluid. This synovial membrane, all of this around here is avascular. As we mentioned how cartilage was avascular, there is no blood supply that goes to that cartilage. There's no blood supply that goes to this joint. So what happens? There's blood vessels that come past these joints, my red blood vessels here, So those blood vessels are going to send nutrients into that area. And that helps to create this clear or pale yellow fluid that has hyaluronic acid. It's technically secreted by synovial cells, but those blood vessels help to contribute to some of that fluid through diffusing some of this into that membrane. This synovial fluid reduces friction between those joints. It helps act as a shock absorption between those joints. It gets oxygen and nutrients to those different cells, that hyaline cartilage, those different cells in the area, and it's going to remove carbon dioxide and different wastes from those chondrocytes, because chondro is cartilage, so cells that are helping to maintain that cartilage in the area. There is phagocytic cells in that area, because what happens if some kind of pathogen, debris, gets in that joint from just normal wear and tear, or some pathogen gets in there? Well, we need a way to protect that joint, because we don't want that joint to get infected, because then it's going to swell up really large. It's going to be really hard to move. If you've ever been immobile, haven't moved for a long period of time, when that synovial fluid in those joints becomes viscous, it becomes thick. But as you move that joint, that fluid starts to thin out. It's something that people in their early 20s, teens, they don't notice that. But as you get older, people tend to notice that it's harder to move your joints the first time you move them. That's why some people, before they even get out of bed in the morning, they stretch. That stretching gets those joints moving, which is going to help to thin out that fluid and make it easier to move. This is some of the benefits to warming up before exercise. I know most people don't. People who do exercise, warming up is kind of something they ignore. But this will help to stimulate production of more synovial fluid to thin out that fluid in those joints, which helps to put less strain on those joints when you are exercising. If you've ever popped any joints, cracking joints, any sound, popping, cracking sounds you hear, sometimes we get gas bubbles in those joints. And when those bubbles pop, that's what creates that cracking sound that you may hear. It's just popping of these gas bubbles in that joint. So me as a chiropractor, when I adjust somebody's joints and you hear that popping, cracking sound, all I'm doing is popping those gas bubbles. But I'm helping to put more movement into those joints, which is allowing those joints to move better, prevent restrictions of those joints so that everything can move easier. Most of our synovial joints are going to have accessory ligaments. These are ligaments that are extracapsular, or they could be intracapsular. So extracapsular means they just lie outside that joint. Intracapsular means they're inside that joint, but they technically don't make up that synovial membrane. In our knee, the ACL, the PCL, the anterior cruciate ligament, the posterior cruciate ligament, those are intracapsular. They're helping to hold that fibula, or that tibia to that femur, sorry. That femur to that tibia. They're helping to hold those two bones together from the inside of that joint. Some of our synovial joints are going to have articular discs or a menisci. Again, our knees, because that bottom of that femur and the top of that tibia don't necessarily fit together very well. So the menisci that we have in our knees allow that femur to fit on top of that tibia a lot better. So a menisci is made of fibrous cartilage, that fibrocartilage. And again, it's helping to allow these two bones to fit together. They work for shock absorption. So when you jump, that femur coming down on that tibia, it's absorbing that shock so that femur doesn't smash into that tibia and break it. As I mentioned before, a better fit between those two bones. It allows for a combination of movements, so your bones to move in multiple directions. It helps to distribute the weight, so that femur down to that tibia, you're distributing all of your body weight down from one bone to the next. So we have to distribute that weight. So those menisci in your knees are going to help do that. And also distribution of that synovial fluid. So it allows that synovial fluid to travel in different areas. Some of our joints have a labrum, your hip and your shoulder. Those are two ball and socket joints. That is technically what they are called. So there's this ring of cartilage that is helping to hold, say, the head of that humerus into that glenoid cavity, or the head of that femur into that acetabulum. That labrum is helping to deepen that socket and help hold those bones in place. A ball and socket joint has the greatest amount of movement. The labrum is helping to kind of restrict some of that movement, but also help maintain that movement. We do have nerve supply that goes to our synovial joints. The same nerves that are going to go to the skeletal muscles that go over that joint are also going to that joint. Those nerves are going to go to that articular capsule and any ligaments that are attached to that joint. These nerves are sending information. They could be sending about pain to that joint. How much that joint may be bent or straightened. Like if you're sitting in a chair right now, what position your knees and your ankles are in. That information is going up to your brain. So when you get up to move, your brain knows your knee is bent at maybe a 90-degree angle. So this is how much it has to straighten for you to stand up. Same with your ankles. Or a stretch to that joint, like a reflex. Think about when the doctor hits that that tendon just below your kneecap. That's that patellar reflex. When they take that hammer and hit that tendon, it's stretching that tendon that's going over that joint and sending back that reflex that quadricep contracts. We'll go into more detail about that when we get to the nervous system and exactly how that works. But these nerves that go to that joint are monitoring this information and sending it back to the brain. As I mentioned, these synovial joints are technically avascular. There's no blood supply that goes into these joints, but there's different arteries in the vicinity, so in that area. So the blood supply that's in that area is going to send oxygen and nutrients into that joint through diffusion. Those veins will remove that carbon dioxide and any waste from those joints, again, through that simple diffusion. bursa. A bursa, I'm sure you may have heard of bursitis. kind of inflammation to that bursa. But what is a bursa exactly? A bursa is kind of like a sac that helps to alleviate some friction to some of our joints. Think of your shoulder. There's bursa that are helping to protect some of the ligaments or tendons from some of the bones and some of the joints in that area. We'll go through them in kind of detail between lab and here. Most of these bursa are that dense irregular connective tissue, and it has a synovial membrane around it, and it's filled with that synovial fluid. So it's like a synovial capsule that wraps around a joint, but it's just that synovial membrane filled with synovial fluid covered in that dense irregular connective tissue that could be sitting somewhere, could be sitting between skin and bone, tendons and bone, muscle and bone, or ligaments and bone. Task question. Knowing where we find bursa. It's going to help cushion some of the movements, but it also helps to protect those ligaments and joints. Torn cartilage. If anybody's ever torn some cartilage, I've cracked cartilage in my knees before, have actual microscopic cracks in it. It happens in athletes a lot. So this damaged cartilage, it could be because of just normal everyday wear and tear. It could be from that overuse that athletes sometimes can do. It can cause arthritis to develop unless that damaged cartilage gets treated. So what they can do is they can make like little tiny, not even half an inch, maybe a quarter of an inch, little tiny incisions into that joint. And what they do is they use little scopes, little cameras, send them into that joint, and they can repair. They can remove torn, damaged cartilage. They can actually repair cruciate ligaments in the knee this way, but they can go in and kind of look around and see what's happening because there's no other imaging, especially that's going to show you damage to cartilage. You may be able to see damage to ligaments on an MRI or a CT. You won't see them on X-ray, but you can't really see damage to that cartilage unless you go in and look at it. So they can fix a menisci. They can remove it if it's like partially torn or something. They can kind of monitor disease like progressions through going in and looking. Right now, that's the best way. That's the best way to see is by going in and looking. There's no other really way to look at some of this stuff. So they can go in and look at this torn menisci. They can go in and cut some of it out. They can repair it. They can do whatever they need to do. But here's an example of torn menisci in through an arthroscopic, looking in through a little tiny camera. They've gone in with this little camera and they can look and see just how extensive this tear is. This is something they'd probably just cut off. Like our bursa, we have tendon sheaths. It's the same idea. I don't have a picture. I thought I did. Sorry. It's the same idea as a bursa, but instead of it sitting between joints, it's going to wrap around tendons. And it helps to reduce friction as these different tendons may go through tunnels. These tendon sheaths, they may have a visceral layer and a parietal layer. So they'll have a layer that's going to wrap directly around that tendon. And then they just have an outer layer that's going to kind of attach to the bones that are around it. They still have that cavity filled with synovial fluid. and it's protecting that tendon. The best example is the biceps brachii in the shoulder. We do have it in our wrists and our ankles that are wrapped in these tendon sheaths that are helping to protect these tendons as they run across bone so they don't wear off and break. Just because certain tendons, the way that they're angled and moved, they could be angled around your ankle bones, should be a tendon sheath around that. So as you like move your foot around, that tendon is, instead of running over one of your ankle bones, there's a tendon sheath there protecting it so it doesn't wear off, break eventually. So I kind of mentioned bursitis. Bursitis is inflammation of that bursa. It can be acute. Acute means it's an injury that happened very recently. Chronic means that it's been around for more than 3 weeks, months, usually. It could be irritation from repeated, excessive movement of that joint. Could be from trauma, did something, an infection, so some kind of pathogen got into there. Rheumatoid arthritis. We'll go through this some more, but rheumatoid arthritis, it's an autoimmune condition, which means your immune system is attacking your own body somewhere. In rheumatoid arthritis, your immune system is attacking your synovial joints. We'll go into more detail about it in a little bit. So bursitis, it's usually pretty painful. They can have swelling of those joints. You push on that area, it's very tender. There's limited movement. They can't move it because it hurts. Anti-inflammatories like NSAIDs, aspirin, or not aspirin, ibuprofen, Motrin, those kinds of medications are anti-inflammatories. They could put cortisol or steroids injected into that bursa to try to calm it down. It just depends on what's causing the bursitis. They look for usually what's causing it for how to treat it. So our synovial joints have different movements depending on how the joints are set up. So let's look at some of these different movements these joints can have. They can have a gliding movement. This is where bones that are pretty flat are moving back and forth or side to side. There's usually some pretty limited movement because, again, of that articular capsule around that synovial joint. And then there's ligaments, and there's usually other bones in the way. Intercarpal, intertarsal, carpal bones, your wrist bones. So if you think you can move your wrist side to side and front to back. Those are those different movements, gliding movements that you can do in your wrist. You can also do that with your ankle bones. They can go front to back and side to side. So it's limited movement. It's not a very wide range of movement, but you're able to still move those bones. Now we're going to get into some other types of movements, angular movements. Those of you who are going into physical therapy, nursing, you will use this. Chiropractic, if anybody's going there, you will use these. These are motions that you'll use to test a patient's range of motion, like how far they can move a joint. I'm going to go to the pictures just because pictures make it easier than me trying to explain it. Like a flexion is a decrease in angle. So here's some examples. Flexion, you put your chin down towards your chest. You bend your elbow up towards your shoulder. That's another flexion. Bend your wrist up towards your forearm. That's flexion. Here's some other ones that are not listed. Flexion, the shoulder joint, moving your hand up towards your head, moving forwards. Bending over, touching your toes. That is also flexion. Bending your knee, so you're bringing your foot towards your bottom. That is also flexion. Extension is that increase in angle. So looking up towards the ceiling, you're flexing, you're extending your head. Extension is moving that hand back behind you, moving that shoulder joint. So your elbow, you flexed your hand up towards your shoulder. Extension is straightening it out. Your wrist, you flexed your hand up towards your forearm. Now you're bending your wrist back the other direction. That is our extension. Bending your back backwards. That's another example. Lateral flexion. Lateral flexion is bending lateral sideways. This does show that flexion and extension of the knee joint and that hip joint. Hyperextension. Hyperextension, a lot of times it's associated with injury, but it's movement beyond that normal range of motion. Those of you who can take your head and bend it all the way back, so like the back of your head rests on your upper back, that is hyperextension. Technically, that's not normal, but it's beyond that normal range of motion. I'm pretty sure that's a test question as well. Being able to bend your head all the way back, that's hyperextension. Now let's look at abduction and adduction. I like to pronounce them that way just because it's the only difference is one letter, abduction versus adduction. Abduction is that movement away from midline. Well, adduction is taking that bone back towards midline. So here's my examples. Your arm. When you abduct your arm, you're taking it out towards the side and up. When you adduct your arm, you're bringing it back down towards the middle. You can abduct and adduct your wrist. So if your hand is in that anatomical position with your pinky with your palm facing out, I should say, your thumb is away from the body, the pinky is closer to the body, you abduct it by bending your wrist towards the thumb. You adduct it by bending your wrist towards your pinky. You can abduct your hip, so your leg out away from midline. Adduct it, brings it back. You can even abduct and adduct your fingers. Abduct, spread your fingers apart. Adduct, bring them all back together. Circumduction is making a circle. So that circumduction, you do that with your shoulder, making that large circle. I think circumduction, circle. It's got the first part of the circle in it, the word circle. So that's where I try to remember for circumduction. And the last one is rotation. So that's moving it along its own longitudinal axis. So you can rotate your head to say no. That is thanks to your C2 vertebrae, that axis that has that dens that sticks up, that articulates with that C1 vertebrae. That is the vertebrae that lets you say no. So you turn your head from side to side. You can medial and laterally rotate your shoulder. You bend your arm at a 90-degree angle at your elbow, and you're able to medially and laterally rotate. Medial towards the body, lateral away. You can medially and laterally rotate your hip joint. So medial, you're going towards the middle. So you're pointing your toes towards the middle, while laterally rotate, you're pointing your toes away from your body. Making sure that hit up every one of those. We also have special movements that can only be done at certain joints. Elevation and depression. Elevation is that superior movement, while depression is that inferior movement. You can elevate. Well, first you depress your jaw. You could opening your mouth. You can elevate it by closing your mouth. You can elevate your shoulders. You can depress your shoulders back down. Protraction and retraction. So it's along that transverse plane, moves anterior. You can protract your mandible. You can stick your teeth, your bottom jaw out. And then retract is putting it back into anatomical position. So here's that example. You take your mandible and move it out, and then you can push it back to retract. Inversion and eversion can only be done with the foot. So inversion, you're taking your foot and pointing your toes towards the middle. Inversion, in. Eversion means you're taking those toes away from that midline. So here's that example, that inversion. So you're taking your toes towards that middle, which would be towards that big toe. Eversion means it's going away. You can only do it with your foot. You will not do it anywhere else. The other one that is only done with the foot is that dorsiflexion and plantar flexion. Dorsiflexion is moving your toes, flexing your foot up, moving your toes towards your tibia. Dorsiflexion got its name because when you flex that foot up, your toes up towards your shin, it kind of looks like the dorsal fin of a shark. That shark, that fin that's on the top of a shark on the back. That's where that dorsiflexion, that's where that term came from. Plantar flexion is pointing your toes towards the ground or standing on your toes. So when you stand up on your toes to look up over something or look at something that's high up, that is plantar flexion. Your book only shows this example, the dorsiflexion, where your toes are coming up towards that shin, that dorsal fin of a shark. That plantar flexion is pointing your toes down towards the ground, or when you stand up on your toes to look at something. I had mentioned before supination and pronation. Supination is where that palm is faced up. Pronation is when that palm is faced down. I mentioned supination has the word up in it, so palm is up. Pronation has the word on in it, so your palm down on the table. So here's that example. Supination, where that palm is up. Pronation is where that palm is down. And the last one is opposition. We are the only species besides monkeys, apes on the planet who can do this because we have that opposable thumb. This is a thumb movement where you can take your thumb, the tip of your thumb, and touch every single finger on your hand. This is that opposition. They're showing it touching your thumb to that little finger, but you can do it with every single finger. This is something that we as a species, we are the only species besides apes and monkeys on this planet who can do this. So this goes through all of these different movements. This is just a summary of all of these movements on one nice chart from your textbook. So let's go into plane movements, more synovial joint type of movements here. So plane movements, you get a back and forth movement and a side to side movement. It's usually between flat surfaces. Plane joints, like those carpals, your wrist bones, those intertarsal, your ankle bones, that acromioclavicular, so in your shoulder, that sternocostal, so between your sternum and your ribs. And then there's vertebrocostal, so between the vertebrae in your back, costal or ribs. They're going to allow, if these joints are biaxial, they allow movement in two different directions. If they are triaxial, they're going to allow movement in three different directions. A hinge joint, your elbow is a really good example. So is your ankle. They allow joints in one direction. You can bend and straighten your arm. That's about it. So the way the bones fit on top of each other, they allow this angular open and closing type of motion. Pivot joint. That atlantoaxial, so between C1 and C2, that joint that allows you to say no. Well, what about that radial ulnar? The head of the radius, kind of that flat. There is a ligament, it's called an annular ligament, that kind of wraps around, and it allows that head of that radius to rotate. So when you pronate and supinate your forearm, that head of that radius is rotating, kind of creating this rotation kind of movement. So it still has that uniaxial, that one motion, but it allows that pronation and supination type of movement of your forearm, or that rotation of your head. An ellipsoid joint. So we have this oval shaped kind of projection that has this kind of oval shaped kind of depression of that other bone that fits together. Radiocarpal, so between the radius and your wrist bones. That's considered an ellipsoid. The metacarpal phalangeal, so the bones that make up your fingers to the bones that make up the palm of your hand. Those are ellipsoid because they allow flexion, extension, abduction, and adduction. You can do limited circumduction. I think you can take some of your fingers and move them in somewhat of a circular motion, like your pointer fingers, maybe your little fingers, your middle finger you usually can, because there's one ligament that attaches to that. But that's what makes up that ellipsoid joint. I have pictures of all of these in a minute. So we have a saddle joint. This is your thumb. It's a saddle shaped. And that articular surface, it kind of fits like sitting on a saddle. They're biaxial plus limited circumduction. but that carpal metacarpal joint between the trapezium and the metacarpal of the thumb, and that sternoclavicular joint. And then the ball and socket. This is the most freely movable. They're triaxial. They move in 3 different directions. That's your shoulder and your hip. It's this ball-like surface that kind of fits into a cup-like depression. So let's look at these. This plain joint. We've got the actual bones, and then we've kind of got a model showing how they move. So thinking the bones in your feet, this bone that's articulating with this bone, they're going to move back and forth, side to side. They allow some circumduction. That hinge joint, the way that ulna fits into that humerus, you can kind of see how it's allowing just that bending and straightening. It doesn't allow any other movement. Here's that pivot joint. I mentioned the head of that radius with that ligament that goes around it. This is what allows that head of that radius to rotate. So when you pronate and supinate, that head of that radius is rotating around it. Here's that ellipsoid joint, how that radius kind of has that kind of cup. Well, that scaphoid and that lunate kind of have that more rounded edge to fit into it. Here's that saddle joint. Saddle joint, think of a horse's saddle. We have one side that is articulating with the other side, the way they fit together. And our ball and socket. You can see this large socket here that makes up that acetabulum, and the head of that femur that's going to fit inside of it. How they come and fit together to allow that 3 axes of motion, that flexion, extension, that abduction, adduction, and circumduction. Those are those 3 different types of movement. So here's these charts directly from your textbook that describe the joint, how they move, and examples of where these joints are all found. So there's just general things that are going to affect your range of motion, how well your joints move. The shape of that joint, how well they fit together is going to determine how well that joint moves. Those ligaments that are holding those joints in place, the tighter or the more tense, the more those ligaments are pulling over that joint, the more restricted the movement's going to be. Muscles. How are those muscles arranged around that joint? And then those soft parts, your skin. So when you bend your arm, that bicep is going to actually contract, and it's actually, depending on how large that bicep is, it could limit some of your movement, so you're not able to move your arm as well. If you've ever seen any of those large bodybuilders that are very bulky with muscle, they have limited joint movement just because their muscles are so large. They can't move their joints in that full range of motion that somebody whose muscles may not be as big could actually move it. Hormones. There is this awesome hormone that is released every month for females with their cycle, and then it's released throughout the entire pregnancy, that is called relaxin. This is going to actually increase the flexibility of some joints. Its main joint to increase flexibility would be that pubic symphysis, so that head of that fetus can fit through that pelvic cavity. And then if you're not using your joints, especially for extended periods of times, those joints may become restricted. They may not move well. They could get locked in certain positions. So it's important to keep moving your joints so your joints maintain that range of motion that they have. So here's charts that are going to go through all of the different joints of the body. We're going to go through several of these in lab if we have not already, that go through the classification of the joints, where they're located, like what's articulating or connecting to what, and what kind of movement they have. So these are some nice joints to kind of help review everything you need for class and lab exams. So let's look at different injuries of different joints, because we're going to we go through in lab all of the different joints, all of the ligaments of the joints, tendons, everything that makes up all of those joints. So let's go through the different injuries. We have rotator cuff injuries. A rotator cuff is in the shoulder, so it could be a strain or a tear to any or muscles of that rotator cuff that make up that shoulder joint. It's common in baseball pitchers, volleyball players, racket sports players, swimmers, violinists. It could be because of just normal wear and tear, aging. There's a lot of people that have some minor tear to muscles in their rotator cuff and never know it. I have one on the right side, I think. I don't remember what I was doing, but we found it one day when I was in chiropractic school. Poor posture can actually play into a rotator cuff injury. Not lifting something correctly. The supraspinatus tendon is the most common tendon that tears. In that supraspinatus fossa, so that in that scapula, there's that supraspinatus fossa. There's that supraspinatus muscle that goes through there and it comes out and it attaches to the humerus. It's going through little tunnels through bones. That is the most common tendon that gets torn somewhere along its path to attach to that humerus. A dislocated shoulder. This is where that head of the humerus comes off of that glenoid cavity. It can cause damage to the ligaments, tendons, and muscles that are helping to hold that humerus in place. Treatment is usually rest, ice, pain relievers, manual manipulation, because that head of that humerus needs to be put back in place so that you can move your arm again. You can't, if it's out of place, you're not going to be able to move it. Sometimes surgery may be needed depending on how bad that dislocation is. Physical therapy may be needed because you need to strengthen that entire shoulder area, because once you dislocate a joint, it's more common to dislocate it again. It has a higher possibility of happening. So by strengthening that shoulder, you're trying to prevent that dislocation from happening again. A separated shoulder, if I could talk. That is between the acromioclavicular joint. So between the acromion process of this scapula and your clavicle. Nice thing with joints is it tells you what bones they are between. And it could be because of a partial or a complete tear of the acromioclavicular ligament that is helping to hold those two bones together. Sometimes it can also involve the corticoclavicular. It's usually because the shoulder hits the ground, kind of falling, landing on your shoulder, is what causes the separated shoulder to happen. Again, rice, price. Rice is at rest, ice, sometimes compression, elevation. Price is at protecting, just adding that protection to it, but it's similar treatment. And then we have a torn glenoid labrum. This is when that fibrous labrum that is helping to hold that head of that humerus into that glenoid cavity tears. You can start to feel this kind of catching feeling when you're moving your arm around, or this kind of feel like it's slipping out of place when you're moving because of that torn glenoid labrum, that humerus head may become dislocated. This is something that surgically needs to be reattached to allow that head of that humerus to stay in that glenoid cavity. You'd have to surgically reattach that glenoid labrum in place. Elbow. We have tennis elbow and little leaguer's elbow. It's just named for the sports that most commonly cause these. Tennis elbow is the lateral epicondyle. Little leaguers is the medial epicondyle. It's just that type of movement that's causing that backhand in tennis versus that pitching. They're using different muscles, so it's causing either the lateral or the medial. So those extensor muscles are involved in tennis elbow. The flexor muscles of that forearm are usually involved in that little leaguers. Dislocation of the radial head. We saw that picture above of that radial head that's sitting inside that ligament. This is why they say not to swing little kids around with an outstretched arm. This is also known as nursemaid's elbow. So when that radial head slides outside of that annular ligament that is holding that radial head in place. It is the most common dislocation in young children. That swinging children can cause that radial head to come out of that annular ligament. And then it's extremely painful for those kids, and they have to manipulate it to put it back into place, which is also very painful. Swollen knee. When someone has a swollen knee, it can be immediately or hours after an injury. And it's usually because of blood that has escaped from damaged blood vessels. The unhappy triad. This is common in hockey players. The tibial collateral ligament, medial meniscus, and the anterior cruciate ligament are all damaged. And then we have a dislocated knee. It's where that tibia is displaced relative to that femur. It's most commonly anterior from an hyperextension of that knee. And it's usually causes damage to that popliteal artery that is going behind the knee. If they don't need surgery, it's that price. Protect, rest, ice, compression, elevation is the most common treatment if surgery is not required for any kind of joint injury. So as we get older, our joints are going to produce less of that synovial fluid, which means they're not going to move as easily as they did when you were younger. That capsule becomes thinner. Those ligaments lose their flexibility that are surrounding those joints. So you're not able to move your joints as well as you used to. Sometimes genetics are going to play a role. Wear and tear is going to play a role in your joints. It can start as early as 20 years old. But most people, it doesn't occur until later on in life. So by the age of 80, almost everyone has some sort of degeneration in their knees, their hips, their elbows, and their shoulders. Osteoarthritis. This is considered age-related degeneration of the joints. Nearly everybody by the age of 70 has some osteoarthritic changes to their joints, which is like a decrease in joint space, wearing of the cartilage in those joints. How you can help maintain your joint mobility. Stretching and exercise can help maintain that range of motion, and it can minimize the effects of aging. Another chapter on why it's important to exercise. Arthroplasty. This is putting artificial joints in. They can put artificial joints in hips, shoulders, and knees. Those are the most commonly done. They can do others, but those are most common. And total versus a partial replacement is going to depend on what type of damage. They have metal, ceramic, or plastic that they can use to help replace those different joints. So in a hip replacement, we have a partial, which involves only the femur, a total, which is going to involve both that acetabulum and the head of the femur. In the knee, a total is when we have damaged cartilage that's removed from the femur, proximal end of the tibia, and the back of the patella. Partial means unicompartmental knee replacement. So only one side of the knee is replaced. So in a hip replacement, we're going to look at a total. So they're going to reshape that acetabulum. So they're going to kind of reshape this back. They're going to take off the head of that femur completely. We have this artificial acetabulum that they're going to put into that hip. And then they've got a new head of the femur. And then this is going to go down into the shaft of that femur. So this is somebody who has had a full total hip replacement. You can see that all new acetabulum, that head of that femur, in this shaft. This goes down into the shaft of that femur to help hold that bone in place. Knee replacement. They've removed the cartilage from that femur over here. They remove the cartilage, the top of the tibia, and the back of the patella. Now they're going to put in new femoral condyles, new tibia with a plastic spacer that kind of mimics those menisci in the knee. And then they're going to attach a new patella. This is somebody who has had a total knee replacement. You see that femur, and you see that portion that makes up that tibia. They don't have the patella shown in here though. So osteoarthritis, I mentioned it is that degenerative joint disease. That joint cartilage is gradually lost. Aging, just a normal result of aging. Obesity causes osteoarthritis to happen earlier because there's all this extra weight being put into the joints, especially the knees. Irritation to your joints, muscle weakness, wear and abrasion can help lead to osteoarthritis, and it's progressive. And it's usually found in those weight-bearing synovial joints. That cartilage is going to slowly degenerate. And eventually, once that cartilage is gone, the ends of the bones are just going to start rubbing together. I thought I had a picture. Maybe not. Osteoarthritis, or no, rheumatoid arthritis. I mentioned rheumatoid arthritis being that autoimmune disease where your immune system is attacking itself. So that rheumatoid arthritis I mentioned is where the immune system is attacking those synovial joints, causing those joints to become inflamed and eventually disfigured. It's bilateral, so it's going to happen on both sides. A lot of times you see it in the hands and the fingers first. Going to cause swelling, pain, and loss of function. This is that rheumatoid arthritis. You can see some of these fingers, you can see that swelling. Here, there's some nice swelling going on. You can see this disfigured of this joint, this bending of this joint sideways. This is common, kind of get the swan neck appearance. You can see it in this finger. It's one of the things that they call it when you look at an x-ray of somebody with rheumatoid arthritis. Kind of get this swan neck appearance in their fingers, this complete disfiguration. And again, it's their immune system attacking these joints, causing this swelling, inflammation, this joint disfiguration. Another one, gouty arthritis. This is more common in males. This is when uric acid builds up, and it's usually in that hallux, that big toe joint. Uric acid is technically a waste product when we break down nucleic acids. Our body is supposed to excrete it in the urine, but if it does not get excreted normally, what can happen is it can start to collect in the joints, and it'll usually collect in that big toe. That whole joint will become very swollen, very inflamed, and this uric acid starts to eat away at the bones and that cartilage. You usually see like white kind of poofy areas in an x-ray. And eventually, if it's left long enough, those joints and that big toe are going to fuse together. And if they fuse together, that means you can no longer bend those joints at your big toe. So think about when you walk and you push off with your back foot, how that toe joint bends. It's no longer able to do that. Lyme disease. This is a tick-borne disease, usually from deer ticks. And if a tick is carrying Lyme disease, they will have this kind of bullseye rash that develops where that tick had bit. And it's usually seen a couple weeks later. People experience joint stiffness, fever, chills, headache, stiff neck, nausea, low back pain. If it's not treated, Lyme disease can be treated with rounds of antibiotics. If it's not treated, arthritis can happen, and it's usually of the larger joints. So the knees, ankles, hips, elbows, wrists. Arthritis is going to develop in those joints. So it's important, if you ever see a bullseye rash, to get it treated as soon as possible. Now, here is something, these are both test questions, knowing the difference, especially if you're going into nursing, physical therapy. You're going to see a lot of these. A sprain is to ligaments. So it's going to be overstretched or torn ligament. A strain is a partially torn muscle or tendon. So sprain is ligaments, strain tendons. They do have a difference. So I mentioned that price, that protect. You want to protect an injury from any further damage. You want to rest it. Telling an athlete to rest from an injury, they kind of like to roll their eyes at you. It's really hard to get them to actually rest. But resting is going to avoid further damage. Icing it. You ice an injury after it happens. Heat is for chronic. Ice is for acute, something that has just happened. Ice will prevent further swelling. It does not reverse swelling. Ice doesn't, but it'll prevent further swelling, things from getting larger. That compression will help reduce that swelling. And then elevation. We want to elevate it above the heart because that'll also help reduce that swelling. Then tenosynovitis. This is tendons. Itis. Anytime we see itis, it is an inflammation. Little medical terminology. Itis, inflammation of tendons. Tendon sheaths or synovial membranes. This can happen in the wrists, shoulders, elbows, finger joints, ankles, and feet. There's an accumulation of that synovial fluid. It can be tender to touch and painful. One more. I like to scare people. A dislocated mandible. So, in a dislocated mandible, your mandible can be displaced anterior, posteriorly, or lateral. If you've ever had any dental work or dental procedures done where they have put you to sleep for those dental procedures, they have most likely dislocated your mandible to be able to get in there to do the surgery. People who've had wisdom teeth pulled and had to be put to sleep, they dislocated your mandible to get those wisdom teeth out. And they will dislocate that mandible anteriorly to be able to get to those teeth to remove them. But it can happen from yawning, taking too large of bites, and they usually do it under general anesthesia if they're going to manually dislocate. They can do posterior. That's usually if somebody gets punched in the mouth. Lateral displacement, your mandible fractures. So that is everything about our joints. Thank you very much for listening and have a wonderful day.